A doctor looked at your scans, reviewed your history, and said you need this treatment. Then a department inside your insurance company looked at a checklist and said no. That department is called utilization management. And here's what they won't tell you. The people reviewing your case are not always doctors. The criteria they use are not the same criteria your physician used. And the reasons they deny you, most of them have absolutely nothing to do with whether you actually need the care. This video is for educational purposes only and is not medical or legal advice. What it is a breakdown of 5 specific administrative tricks that insurance companies use to deny prior authorization, and none of them touch your medical record. If you or someone you know has ever gotten a denial letter that felt wrong, this is the explanation you were never given. Prior authorization, called prior auth, is the process where your insurance company decides in advance whether it will pay for a treatment your doctor wants to give you. On paper, it sounds reasonable. In practice, it has become one of the most powerful cost-cutting tools the insurance industry has ever built. In 2023, the American Medical Association surveyed physicians across the country. 94% of them said prior authorization had delayed necessary care for their patients. 33% said it had led to a serious adverse event, meaning a patient got sicker or worse because the insurer said wait. But here's the part the insurance companies don't advertise. Many of the denials that drive those numbers are not clinical decisions. They're administrative ones. A wrong code, a missing modifier, a criteria version from last year applied to this year's request. These are not medical judgments. They are system features. And they are designed, not accidental. The CFPB, the Consumer Financial Protection Bureau, and state insurance commissioners across the country have documented this pattern. In 2024, new federal rules under the No Surprises Act framework pushed insurers to speed up prior auth timelines, but the denial machinery itself, that stayed intact. Knowing how it works is the only way to fight it. So here are the 5 tricks. And once you see them, you can't unsee them. Trick number 1 is the NPI taxonomy code mismatch. Every physician in the United States has a national provider identifier, an NPI number. That number also carries a taxonomy code, which is a classification that describes what kind of provider they are. A general surgeon has one taxonomy code. A vascular surgeon has a different one. A hand surgeon has another. Here's where the trap is. When your doctor submits a prior auth request, the insurance company's system cross-references the taxonomy code on the request against what's in their credentialing database for that provider. If those 2 codes don't match exactly, the system can auto-deny the request before a human ever reads it. Not because the doctor isn't qualified, not because the treatment is wrong, but because a database field doesn't line up. In some cases, physicians have been credentialed under one taxonomy code by the insurer, but are practicing under a second specialty. The mismatch is a system error, but the denial letter goes to the patient as if it were a clinical decision. Patients who've been denied for this reason often get a letter citing something like, quote, provider not authorized to perform this service, end quote. That sounds clinical. It is not. It means a code field didn't match. Has something like this happened to you? A denial that felt like it had nothing to do with your actual situation? Tell us below. What was the reason they gave you? Trick number 2 is step therapy protocol abuse. Step therapy, also called fail first, is when an insurer requires a patient to try a cheaper drug or treatment before it will approve the one the doctor actually prescribed. The official justification is cost effectiveness. The practical reality is that insurers set their own step therapy sequences, and those sequences do not have to match clinical guidelines. Here's the mechanism. The insurer's formulary, its approved drug list, has a hierarchy. The doctor prescribes treatment C. The insurer says you have to try treatment A and then treatment B first and document that they failed before we'll cover C. That documentation process can take months. And if the documentation isn't submitted in a very specific format, with specific failure criteria, the insurer can deny the step therapy exception request and restart the clock. 29 states now have step therapy reform laws on the books, according to the National Alliance on Mental Illness and the Arthritis Foundation. But enforcement varies wildly. And in states without those laws, or in self-funded employer health plans governed by ERISA, instead of state law, the insurer's internal protocol is essentially the only rule that applies. ERISA, the Employee Retirement Income Security Act of 1974, governs most employer-sponsored health plans. And it creates a legal firewall that blocks patients from suing insurers under state law. That's a separate conversation. But it's the reason why the step therapy trap is so much harder to escape in an employer plan than in an individual market plan. Trick number 3 is peer-to-peer review timing manipulation. When a prior auth is denied, most patients know they have the right to appeal, but many don't know that physicians also have the right to request what's called peer-to-peer review. That's a direct conversation between your doctor and the insurer's medical reviewer, where your doctor can argue the clinical case in real time. Here's the trick. Insurers are required to make peer-to-peer reviews available, but they control when those calls can happen. The window is often narrow. Some insurers give physicians 48 to 72 hours to request the peer-to-peer. After that, the denial is final for that level of review. And those 48 hours, they start from when the insurer sends the denial notice, not from when the physician's office actually receives it or even opens it. Internal data from physician advocacy groups has documented cases where the peer-to-peer window closed before the denial letter was even processed by the doctor's front desk. The clock ran out before anyone knew it had started. If your doctor is fighting a prior auth denial right now, the single most important question to ask the insurer's representative is, when exactly did the peer-to-peer window open and when does it close? Get that in writing. Because if that window expires, the insurer can legally say the physician failed to exercise their review rights and use that as justification to move the denial to the next level without a clinical conversation ever happening. That's not medicine. That's a calendar trick. Trick number 4 is criteria version misalignment. Insurance companies don't use their own clinical criteria to make utilization management decisions. They use third-party criteria systems. The two dominant ones are InterQual, owned by Change Healthcare, which is now part of United Health Group, and MCG Health, formerly Milliman Care Guidelines. These are proprietary databases that define what counts as medically necessary for thousands of procedures and diagnoses. Here's the problem. Both InterQual and MCG update their criteria sets annually. Insurers contract for a specific version. And here's what the contract doesn't require: that the insurer use the current version. So in practice, a patient in 2025 can have their prior auth evaluated against InterQual criteria from 2022, because that's the version the insurer licensed and hasn't updated. Meanwhile, the physician submitted documentation based on current clinical guidelines, which may have evolved in the intervening 3 years. The criteria don't match. The request gets denied, and the denial letter won't say which version of InterQual was used. You'd have to specifically request that in the appeal, citing your right to the full criteria under your plan's coverage determination process. The criteria version used in your denial is information you're entitled to. Under the Mental Health Parity and Addiction Equity Act and under ACA internal appeals rules, you have the right to request the specific criteria that were applied. Most people never ask. Most insurers never volunteer it. If that would have saved someone you know from a wrongful denial, this is exactly the kind of thing we break down here every week. If you're not subscribed yet, that's the reason to be. We go through what insurance companies hide in plain English every single week. Trick number 5 is the place of service code trap. This one is almost entirely invisible to patients and is one of the most common administrative denial triggers that exists. Every medical service has 2 layers of coding. There's the procedure code, which describes what was done. And there's the place of service code, a 2-digit number that tells the insurer where the service happened. Code 11 is a physician office. Code 22 is an outpatient hospital. Code 24 is an ambulatory surgical center. Code 21 is inpatient hospital. When a prior auth is submitted, the place of service code on the auth request must match the place of service code that will appear on the eventual claim. If the procedure gets authorized for code 22, an outpatient hospital setting, but the service actually happens in a code 24, an ambulatory surgical center, the claim can be denied even though the procedure itself was authorized. The authorization exists. The service happened. The code didn't match. Insurers call this a billing discrepancy. What it actually is a technical tripwire that voids a valid authorization on a 1-digit difference. Research published in the Journal of the American Medical Association found that administrative billing errors, including code mismatches, account for an estimated $80 billion in unnecessary healthcare costs annually. Not all of that is prior auth related, but the code mismatch pattern shows up consistently in denial audit data from state insurance commissioners. Before the last thing we cover today, a question. What has been the biggest insurance or consumer rights issue you've run into? Whether it's a denial, a billing fight, a claim dispute. Tell us below. Your specific situation might become our next video. Now, knowing the 5 tricks is one thing, but there are 3 mistakes that people make when they try to fight a prior auth denial, and these mistakes hand the insurer an easy win. Mistake number 1, appealing on clinical grounds alone when the denial was administrative. This is the most common error. A patient or their doctor gets a denial, reads the letter, and immediately starts building a clinical argument, pulling journal articles, writing a letter of medical necessity. But if the denial was triggered by an NPI taxonomy mismatch or a place of service code error, a clinical argument doesn't fix it. The system rejected the request at the administrative level. The appeal has to be targeted at the same level. The first step is always to identify what type of denial it is, clinical or administrative. Those require completely different appeals. Mistake number 2, missing the internal appeal deadline. Under the Affordable Care Act, health plans are required to allow internal appeals, and then, if that fails, external review by an independent organization. But the internal appeal window for most plans is 180 days from the denial date. For urgent or expedited situations, the clock is much shorter, sometimes 72 hours. People lose winnable appeals every single day because they waited too long. The denial felt overwhelming. They set it aside, and then the window closed. Some plans require the appeal to be received within the window, not just postmarked. That distinction alone has ended thousands of valid claims. Mistake number 3, not requesting the full claims file. Under ERISA and under ACA regulations, patients have the right to request the complete claims file from their insurer. That file includes the specific criteria used in the denial, the identity and credentials of the reviewer who made the decision, all correspondence, and the internal notes from the utilization management decision. Most people have never heard of this right, and insurers do not volunteer it. But that file is where the criteria version lives. It's where you find out whether the reviewer was a physician, a nurse, or a non-clinical screener. It's where you find the exact code error that triggered the administrative denial. Requesting that file in writing within the first 2 weeks of receiving a denial gives any appeal a foundation that most insurers do not expect the patient to have. So here's what all 5 tricks have in common. None of them are about whether you need the care. Every single one of them is a system designed to create a denial before a clinical decision ever has to be made. The insurer reduces cost. You lose access. And the letter you receive is written to sound medical when the decision wasn't. That's not an accident. That's the design. If you're dealing with a prior auth denial right now, there's a video already up on this channel that walks through exactly how to write an internal appeal letter that insurers actually have to respond to. It covers the specific language that triggers your rights under ERISA and the ACA. That's the next step. It's already there. And if you've made it this far, you already know more about how prior authorization actually works than most people ever find out. That's what we do here every week. We take the systems that are designed to work against you, and we explain how to fight back in plain English.